So this is the colonoscopic features. What's this one? You see, it's continuous lesion, and I think this is the lesion is very superficial, maybe just in the mucosa. So it's hyperemic mucosa. Sometimes maybe it will have ulcerations, but not all of the patients have ulcerations. The name is ulcerative colonitis, but ulceration is not every patient have ulcerations. So the typical lesion is hyperemic mucosa. But for the CD, you see, it's called a cobblestone.
It's not ulcerated, right? It is not ulcerated.
This is ulcerated. No, this is not ulcerated. It's just hyperemic. I mentioned that not all of the UC patients have the ulceration. Maybe half, maybe less. And this Crohn's disease cobblestone. But this is a very typical one. But it's in some mild Crohn's disease, they're not so typical cobblestone appearance. It's difficult to do the distinguish diagnosis of this one.
Which part is this one?
Colon? I don't know which part of colon. From this appearance, you cannot see, which transverse or ascending. No, that is. But for the normal ball, from the colonic, for the scopic appearance, maybe you can make some different appearance. For the transverse column, transangle appearance, the typical one, transangle. And to the descending column, you may directly see the ileocolic valve. So there's some features of different part of colon. Okay. So go back. So why we do UC and CD different disease? Because different operation treatment. For the UC, total colectomy, so whole colon rectum, colon and rectum different. So it's a total colectomy. If the only colectomy, total colectomy, just the colon, proctal rectum. So the total colectomy for UC is curative. After operations, the patient will not recur, no recurrence. But some patients, if first maybe you diagnose the ulcerative colitis, then he or she receives this total proctal colectomy. But after several years, the disease recurrence, then maybe we should consider it is CD. Because 10 to 15% of patients at the first diagnosis is called intermediate, cannot make a distinct difference. So, yeah. For the CD, usually no. So segmental resection rare. For the UC, we mostly do the total proctal colectomies, but of CD, segmental resection is maybe popular because it is a segmental disease and it's pan-gastrointestinal disease. If you take off all the colon rectum, maybe it will happen in the small intestine. You cannot remove all of the small intestines. So it's better to preserve as much as intestines or balls as much as possible. Okay, and this ileal purge is performed by most patients. The ileal purge I will explain later in detail. But the CD is contraindication. So for the ulcerative colitis, the most common surgical procedure is total proctal colectomy with ileal approach. Because if you remove all the column rectum way, then you do another anastomosis for any part of ileum to the anus. Everyone knows that the fluid, the ileum, the content is in fluid. If the fluid go directly from the anus, it will cause the infection or some edema of your anus area. So and also you cannot control your pickles if oil is liquid. So we use ileal pouch to small intestine together form a large lumen. So I will explain it later to you. And the complications, post-operative recurrence, no. Well, you see, I think if you receive this operation, no one will recurrence. But for CD, a lot of recurrence. And one of my postgraduate students, he had this Crohn's disease. And he received the right hemicolectomy when he is at high school. But these days, because maybe the examination these days, high attention, okay, then she feel pain of abdomen, maybe some diarrhea. So the CD, it will recurrence very high. And the fistula, I see, I just mentioned is mostly in CD. Okay, so do you have already learned something about the liver pancreatic disease? Yeah? Okay, so sclerosing cholangitis, the UC patient maybe have a sclerosing cholangitis. But for the cholestasis, CD, there's no. Also the nephrolysis, the stone in the kidney, stone in the bile duct, CD. So this is also some colonoscopic pictures. Maybe this, I think some ulcerations. Yeah, this is ulcerations.
Which one? This white patches?
Yeah, white patch. So this afternoon, someone will go with me to the first affiliate hospital. So I will try to show you this. If there are some patients here. Any question? No.
I have a question.
Okay.
Can you diagnose, use your CD just by looking at this image?
It's just suspected diagnosis.
So what could be the suspected diagnosis?
Yeah, maybe this. You see, if you have the clinical features, diarrhea, hemorrhagic figures, and have the colonic.
Clinical features are overlapping.
Yeah, overlapping. Yeah.
So let's come back to this image. From this
It
image,
is continuous lesion.
continuously.
Lesion, yeah. But if the lesion is discontinuous, maybe it's CD. But sometimes it's very difficult to do the diagnosis. So why is there so many features of CD or UC? I explained so many times. But sometimes it's very difficult to distinguish differential diagnosis between. Yeah. So first is clinical features, then the colonic appearance, then we do the biopsy. Biopsy.
How does biopsy help us?
Happens? Yeah. Microscopic appearance.
Oh, microscope.
Yeah. So the pathologist may be just to present the report. It said chronic inflammatory change. So usually in the clinic we do the diagnosis of UC, not the CD. And I think it's no matter because the medical therapy for UC and CD almost the same. The medical almost the same, but for operation totally different. So for the typical one, diagnosis is easier. For some mild patient, it's very difficult, I think. So this is why at the very beginning I mentioned that 10 to 15% is called intermediate. And even some patient receive this total block colectomy ileal pouch because we diagnosed UC after 10, several years, it returns. So you see it's difficult to diagnose? Yes. So the total protocolectomy. So the typical gross appearance is hyperemia mucosa, hypomelia. But this is because for the congestion of venous congestion, so it's even darker. But the typical appearance is hyperemic mucosa and friable and granular mucosa. So it's common in more severe cases. So this patient is a severe patient, cause massive bleeding. So he receives operation. Not all the UC patients should receive operation. Most of them only take medicine. The drug you can cure, you can palliative the symptom. So ulceration is not invariable present, may appear and very widely, may appear. So some patients have no ulcerations.
Do you know which part is this? Do you know which part is this?
Whole colon and rectum. Yeah. Just this is rectum, ascending, transverse, descending sigmoid. The shape is not so good, but like this.
So how does the patient defecate?
Mm-hmm.
How does the patient defecate if you remove all the...
Defecate? So if the younger patient or the general condition is good, we do first the resection, then do the ileal pouch. Then the pouch and anal anastomosis. So most patient, if she or he receive operation, this is the typical surgery. But some patient, we only do remove all the colon rectum and do the permanent ileostomy. The fecals go through the otomy from the abdomen, not from the anus. Some part, especially in an elder patient, the sphincter function is not so good. And if you do anastomosis, your anal sphincter cannot control your fecal.
How about the absorption of water and electrolytes?
The ileum maybe will adapt this situation. They will absorb some water. So for 1 or 2 years, the fecal will become solid. But after the very near your operation time, the patient maybe will 10 times per day for diarrhea. But gradually, the ileum will become to absorb waters, the fecal will become dry. And you can use some drugs to control the fecal, because to reduce the movement, so the water can be absorbed in the small intestine. So this is the gross appearance of chronic disease. The longitudinal, you see this very deep longitudinal ulcerations. So this is just a part of the, and this is a CD cost construction.
This is the lumen?
Human, yeah, human.
The lumen.
Lumen, yes, lumen. Just cut it. So this part is the constriction and cause the bowel obstruction. So the patient receives the operation, just cut. The lesion which is involved is called segmental resection.
Rarely we do this type of operation.
Yeah.
For CD.
Yeah. So this after ulcer, I'm not because the This picture I copied from the internet. I never see this after before. So this is only present in the CD. Maybe it's here after ulcer. Okay. This is also the cobblestone appearance, and this maybe cause stenosis later. So this cobblestone erythema pattern. Which maybe this place later will cause. Now it's stenosis. Later, maybe we'll got the obstruction. So this is all the cobblestone shape. And what do you think of this one? Maybe you think, oh, it's cancer. Yes. Sometimes it's very difficult to just for your eye to distinguish which is UC, CD, or this is a CD, because you do the biopsy. For usually we do 3 to 5 different place site biopsy. All sites the pathology show is maybe granuloma, or something like this. So
biopsy of the mucosa layer only, or just the lesion?
Lesion.
So just we take this
lesion. This lesion. So sometimes the lymphoma near the ileum colic area also have the same appearance like cancer. So the lymphoma is the hematologist disease. But if lymphoma causes obstruction, we should cut it. Sometimes you just use drugs, it's okay. So this is the Crohn disease. What's this one? So fistula, because of fistula. And this is deep longitudinal ulcers. So just with the longitudinal, we just along the lumen. So this is this way. Also the cobblestone. Okay. So this air-down track enema for Crohn disease. So there's some polyps, a lot of polyps. So it also provides useful information, making a diagnosis and determine the extent of the disease. But in our hospital, we seldom do this enema.
Cobblestone like mucosal patterns, can you call them polyps?
What?
Polyps.
Polyps? No, this is not polyps. Polyps are very. This is also CD. Maybe this is a polyps. Something.
Protruding.
Yeah.
So only the first stages of polyps is they have this cobblestone like mucosal pattern.
No.
First stage is when
No. Cobblestone because maybe the segmental area of this colon. The whole, I think the whole area, the segmental, have the same shape. But for the polyps, maybe only 1 or 2, not to form the whole plane, I think. So the medical therapy for UC, there are 3 different kinds of medications. One is aminosalic and salates. So this is 5-ASA. This is mostly commonly used, especially in mild or moderate patients. And if this is not effective, then we try corticosteroid. And if this is not useful, then we try immunomodulatory drugs. So cyclosporine we mostly use in the transplantation. So it can also be used for the UC.
So these treatments are based on what?
Which one?
For example, immunomodulated drugs.
Yeah.
Why do we prescribe these drugs? They're not immunocompromised.
From etiology, we are unclear. But it's a should be something related to the immune response. I have mentioned in the previously for the etiology of this disease. So this is effective. But I never try to use these drugs. If the patient should use these drugs.
But it can suppress the immune system.
Yes. So only in very we use these drugs, but not in our department. Because our department we used to do the surgery. If the patient should use immunomodulators drugs, it should be transferred to which gastroenterology interdepartment.
GI department.
GI department, yeah. Okay.
And
It's useful.
But we don't know the etiology.
Yeah, sure. Many of the drugs, the diseases, we don't know the etiologies.
but we give drugs, and if they are well treated, if they respond to the drug,
Yeah,
this means that we can come to know some etiology of the.
maybe.
Right.
I think it shouldn't be related, this kind of 2 disease should be related to some immune disorders. Yes, many of these researchers in the literature, you can, if you have some time later, you can find many of these research of immunological response and the UC and CD. So, okay. So the medical therapy for CD are the same, but the infliximab, you know this one. So it's a new drug. It's anti-TNF-alpha antibody. It can block the TNF-alpha receptor in an effort to decrease inflammation. So it can be used in chronic draining fistula. So this drug mostly is used in hematologists. But in our department, if the Crohn's disease patient have fistulas, incurable fistulas, we can try infliximab. So this infliximab cannot use in UC. Okay.
For fistulas, we can do surgical operation.
Which one?
For fistula, we can do surgery.
Yeah, but when the patient has UC or CD, especially CD, the patient have the disease is active, you cannot do the fistula operation. If you do this fistula operation, the operation site cannot heal. So it's better just to drain. We do some operation to drain the fistula, but not cut the fistula. Otherwise, it will, for several months, several years, cannot heal. So now we talk indications. You ask so many questions. So what kind of UC patient should receive the operation? So first, intractable disease. The second is cancer carcinoma, which should be received operation. Massive bleeding, even cause hemorrhagic shock. You have to do this operation. And also, it's called toxic megacolon. The colon may be more than 10-15 centimeters large. It will cause operation. The toxic inside the lumbar will absorb and then cause the shock. So the toxic megacolon should be received the operation. It's called fulminant colitis. And also in young patient, malnutrition and growth retardation. So this is the indication for UC. Not most of patients receive the medication is okay, but for some patients, yeah. So this is operation choice. There are several choices. So one of your students just asked me, ileostomy is okay? It's okay. Remove all the colon, rectum, then do the ileostomy. Which people? with fecal incontinence. Okay, so most common definitive operation is here: total prostatectomy with ileal pouch anal anastomosis, IPAA. It's a popular surgical procedure all over the world. This one. So there are different pouch. So the ileum, the J pouch, like J, and this S pouch, and this W pouch and H pouch. And then mostly we prefer to do J pouch. It's relatively easier to do. So most surgeons like to do the J pouch. Sometimes we use W pouch. So if you do the pouch, the content of the intestinal lumen will enlarge. So you can store your fecals inside and also absorb some water, something. And because the movement of the ball is from here this way, and if you do the pouch, there's disordered movement, so the fecal will stay in your pouch for a longer time. So this is why we do this pouch. Okay, so this common definitive operation is total prostatectomy with ileal pouch anal anastomosis. And after we do this operation, usually we do the temporary ileostomy. Temporary is okay. After we do the anastomosis, 10 to 20 centimeter proximal part of the ileum will take out, then do ostomy. This ostomy is called temporary ileostomy, only used for the fecal diversion. After operation, after you take your meat, the fecal go from your ostomy site, will not go through your anastomosis site, and it will protect your anastomosis. If there's any leakage, it will not cause severe infection. If without this temporary ileostomy, the fecals go through your anastomosis site and will go to the leakage site, will cause infection. The patient maybe have a higher temperature, white blood cell count very higher. Maybe he or she should receive reoperation.
And the total prostatectomy, we also remove the rectum?
Yes.
The whole rectum is removed?
Yes.
So what do we anastomose the iliac to which part of the...
Anal.
So directly to...
Anal. It's anal. Anal canal. So the most distal part of the alimentary tract, anal, is the anal. So indication CD. Others are the same, like close you see, but one is intestinal obstruction because the CD will involve the intestinal lesions or into the abdominal abscess. And sometimes it will cause perforation, then form the abscess, also fistula. So another is the same. So the intention for surgery for Crohn's disease is one, relieve symptom. The second is correct complications. The third is prevent development of cancer because it's a pancreatitis disease, and therefore surgical intervention may not cure the patient. So this is the intentions for surgery. You can understand this? Okay, pass. So then we to the third part. The most important part of today's topic is colorectal neoplasia. And there's two parts, the polyps and the cancer. What is a polyps? So any mass projecting into the lumen of the ball above the surface of the intestinal epithelium. So any